Welcome to the ICU Nursing Education course on AKI, CKD, and IHD. In this session, we'll explore three major kidney conditions that every ICU nurse should understand: acute kidney injury, chronic kidney disease, and intermittent hemodialysis. Through this course, you'll learn how to recognize early warning signs, apply nursing interventions, and support patients throughout their treatment journey. Let's begin our journey into understanding how the kidneys work and why their function is so vital to life. Here's a quick look at what we'll cover today. First, we'll talk about how the kidneys work and how to check their function. Then we'll go through three main kidney problems: AKI, CKD, and hemodialysis. We'll also review common electrolyte issues and the key points of nursing care and documentation. In the end, we'll talk about prevention, patient education, and do a short summary. All right, let's begin with the first part, the role and function of the kidneys. Let's start by understanding what the kidneys actually do. The kidneys keep our body in balance. They filter waste and extra fluid from the blood, regulate electrolytes and acid, base balance, and help control blood pressure through the RAAS system. They also produce erythropoietin, which helps make red blood cells, and activate vitamin D for healthy bones. Each kidney has more than 1 million nephrons working together to filter and reabsorb what the body needs. When the kidneys don't work well, waste builds up, BUN and creatinine levels rise, and patients can develop swelling, high blood pressure, and electrolyte problems. So, understanding normal kidney function is the first step in caring for patients with AKI, CKD, and those on hemodialysis. The kidneys have four main jobs. They filter waste from the blood, reabsorb water and what the body needs, secrete extra ions and drugs, and through endocrine function, make hormones like renin, EPO, and activate vitamin D. All these keep the body balanced and healthy. Renal function tests tell us how well the kidneys are working. They show the kidney's ability to filter waste, keep fluids and electrolytes in balance, and remove toxins from the body. The most common ones are BUN, creatinine, and electrolytes, sodium, potassium, and chloride. Here are the key lab values we check for kidney function. BUN shows protein metabolism and kidney excretion. Creatinine reflects how well the kidneys filter the blood. It's one of the most important indicators. Sodium helps maintain fluid balance. Potassium affects the heart rhythm and muscle contraction, so even small changes matter. And chloride helps keep the body's acid-base balance stable. For nurses, the key is daily monitoring. Check BUN and creatinine every day for any changes. If you notice rising values or low urine output, less than 0.5 milliliters per kilogram per hour, report it right away. Also, watch for edema, confusion, arrhythmia, or signs of fluid overload. And finally, encourage hydration when it's safe to do so. Next, let's move on to acute kidney injury, or AKI. This is one of the most common and serious problems in the ICU. It happens suddenly and can affect how the body handles fluids and waste. In the next few slides, we'll look at what causes AKI, how to recognize it early, and the key points for nursing care. Acute kidney injury means a sudden drop in kidney function. When this happens, waste and fluid build up, and electrolytes become imbalanced. The good news is, AKI is often reversible if treated early. According to KDIGO 2021, AKI is diagnosed when creatinine increases by 0.3 milligrams per deciliter within 48 hours, or rises to 1.5 times the baseline within 7 days, or when urine output is less than 0.5 milliliters per kilogram per hour for more than 6 hours. There are three main types of AKI: pre-renal, caused by dehydration, blood loss, or heart failure. It's the most common type, and the key is to restore circulation early. Intrinsic happens when the kidney itself is damaged, such as acute tubular necrosis or nephrotoxic drugs. Here, stop the toxins and monitor urine and lab results closely. Post-renal, caused by obstruction, like stones, enlarged prostate, or tumors. The goal is to relieve the blockage, for example, with a catheter or stent. In acute kidney injury, the first thing we often see is oliguria or even anuria, very little or no urine. Next comes edema and fluid overload, because the body can't remove excess water. Patients may feel nausea, vomiting, or fatigue, and sometimes develop confusion or decreased consciousness. Lab results will show high BUN, creatinine, and potassium levels. These are all signs that the kidneys are struggling and need prompt management. For patients with AKI, nursing care focuses on close monitoring and early action. Check vital signs, urine output, and daily weight. Record intake and output carefully. Accuracy really matters here. Stop or avoid nephrotoxic drugs, like NSAIDs or contrast dye. Adjust fluid therapy as ordered, and prepare for dialysis if needed, especially in hyperkalemia or acidosis. Lastly, teach patients about hydration and medication safety. Remember, AKI is common but reversible when detected early, and nurses play a key role in preventing complications. Now let's move on to chronic kidney disease, or CKD. Unlike AKI, CKD develops slowly over time and causes a gradual, permanent loss of kidney function. It's a long-term condition that often goes unnoticed until it becomes advanced. Let's take a look at what defines CKD and why early detection is so important. Chronic kidney disease is a progressive and irreversible loss of kidney function that lasts more than 3 months. It's defined in 2 ways. First, when the GFR is below 60 milliliters per minute for over 3 months, or second, when there's evidence of kidney damage, such as protein in the urine, structural changes, or biopsy findings. CKD often develops silently, so many patients don't notice it until it reaches advanced stages. Chronic kidney disease is divided into 5 stages, based on the GFR level. In stage 1, GFR is still normal, above 90, but there's kidney damage. Stage 2 means a mild decrease, between 60 and 89. In stage 3, the GFR drops to between 30 and 59. We often split this into 3A and 3B, showing moderate decline. Stage 4 is severe, with GFR between 15 and 29. And finally, stage 5, also called end-stage renal disease, means GFR is below 15 and dialysis is usually needed. The main causes of chronic kidney disease are diabetes and hypertension. Together, they account for most cases. Other causes include glomerulonephritis, long-term use of nephrotoxic drugs, and polycystic kidney disease. Clinically, patients may feel fatigue and loss of appetite, or show swelling in the legs, hands, or face. They can also have nausea, vomiting, and high blood pressure. In later stages, anemia and bone pain may appear as the disease progresses. For patients with chronic kidney disease, nursing care focuses on long-term monitoring and education. Check blood pressure, urine output, and daily weight regularly. Teach patients about diet control, fluid balance, and taking medications as prescribed. Encourage early and regular follow-up to prevent complications. When kidney function declines further, prepare the patient for dialysis or transplant if needed. Remember, CKD progresses slowly, but the damage is irreversible, so early control of blood pressure, blood sugar, and lifestyle habits can slow it down. Now let's talk about intermittent hemodialysis, or IHD. When kidney function declines severely, dialysis becomes a life-saving treatment. IHD is one of the most common forms of renal replacement therapy, helping remove waste, excess fluid, and electrolytes from the blood. Let's look at how it works when it's needed and what nurses should focus on during dialysis care. Intermittent hemodialysis, or IHD, is a renal replacement therapy that removes waste, extra fluid, and electrolytes from the blood using a dialyzer. It's usually done 2 to 4 times a week for patients with AKI, or CKD, and each session lasts about 3 to 5 hours. In simple terms, IHD works like an artificial kidney. It cleans the blood through diffusion and ultrafiltration. Hemodialysis is started when the body can no longer maintain balance on its own. The main indications include severe hyperkalemia, metabolic acidosis, and fluid overload that doesn't respond to diuretics. It's also used for uremic symptoms, such as confusion, pericarditis, or encephalopathy. Other reasons include drug overdose, when the toxin can be dialyzed, and end-stage renal disease, where kidney function has completely failed. During hemodialysis, several complications can occur, so nurses must stay alert. Hypotension is the most common one. It happens when fluid is removed too quickly. If this occurs, stop dialysis, elevate the legs, and give fluids if needed. Muscle cramps result from fluid or electrolyte shifts. Slow the ultrafiltration rate, stretch the muscles, or apply a warm compress. Dialysis disequilibrium syndrome, or DDS, can occur when urea drops too fast, leading to headache or confusion. Slow the dialysis rate and monitor the patient closely. Finally, infection can happen from vascular access contamination. Always use a septic technique and check the site and temperature regularly. Let's review the key nursing steps for hemodialysis. Before dialysis, check the patient's vital signs and weight, and assess the vascular access for thrill, bruit, or any signs of infection. Hold antihypertensive medications if the doctor orders, to prevent low blood pressure during treatment. During dialysis, monitor the blood pressure every 15 to 30 minutes and watch for cramps, dizziness, or hypotension. After dialysis, recheck the vitals and weight, inspect the access site for bleeding, and observe for fatigue, headache, or fever. Each step helps ensure patient safety throughout the procedure. Patient education is essential for dialysis safety. Remind patients to keep their vascular access clean and dry at all times. They should never measure blood pressure or draw blood from the access arm. Tell them to report any bleeding, redness, or swelling immediately. Also, emphasize the importance of following fluid and diet restrictions strictly. Hemodialysis saves lives, but it depends on precise nursing care and good patient cooperation to prevent complications. Next, let's talk about electrolyte imbalance, a common and critical issue in kidney disease. When the kidneys fail to filter properly, electrolytes like sodium, potassium, and bicarbonate can easily go out of balance. Even small changes can cause serious effects on the heart, brain, and muscles. In the next slides, we'll look at the most important ones: hyperkalemia, hyponatremia, and metabolic acidosis. Electrolyte imbalance happens when the levels of key ions, sodium, potassium, and bicarbonate, become abnormal. This is very common in renal failure because the kidneys can't filter and excrete properly. Among all, hyperkalemia, hyponatremia, and metabolic acidosis are the most critical for nurses to recognize early and monitor closely. Let's review the three most common electrolyte problems in renal failure. First, hyperkalemia, when potassium is above 5. It's often caused by renal failure, acidosis, or potassium-sparing drugs. Patients may have muscle weakness, tingling, or peak T waves on ECG. We manage it by restricting potassium, giving calcium gluconate to protect the heart, insulin with glucose to shift potassium into cells, or dialysis to remove it. Next, hyponatremia, when sodium falls below 135. Common causes are fluid overload, heart failure, or excessive water intake. Symptoms include headache, confusion, and seizures. The treatment is fluid restriction, slow sodium correction, and treating the underlying cause. Finally, metabolic acidosis, seen when the kidneys can't remove acid or retain bicarbonate. Patients show deep, rapid breathing called Kussmaul respirations with fatigue or confusion. We treat the cause, give IV sodium bicarbonate if severe, and prepare for dialysis if acidosis continues. For patients with electrolyte imbalance, nursing monitoring is critical. Check electrolyte levels and ECG closely to detect early changes. Watch for muscle weakness, irregular pulse, or mental confusion. These can be warning signs. Educate patients to avoid high potassium foods like bananas, oranges, and tomatoes. And always report critical lab values to the physician immediately. Remember, electrolyte imbalance can cause life-threatening arrhythmias, so early detection saves lives. Next, let's talk about nursing assessment and documentation. In the ICU, accurate assessment and clear records are vital for patient safety. Even small changes in vitals or urine output can mean a lot, so always observe carefully and document on time. Accurate assessment and documentation help us detect early kidney changes, ensure continuity of care, and support clinical decisions. In the ICU, even small changes in urine output, blood pressure, or labs can signal worsening kidney function, so every detail matters. In renal patients, nursing assessment must be systematic and consistent. Check vital signs. Low blood pressure may reduce kidney perfusion. Monitor urine output hourly. Report if it's less than 0.5 milliliters per kg per hour for 6 hours. Record intake and output carefully, including for fluids and losses. Weigh the patient daily. Remember, 1 kilogram equals about 1 liter of fluid. Assess for edema or lung crackles, which can mean fluid overload. Finally, review lab results. Pay attention to BUN, creatinine, potassium, sodium, and bicarbonate. Every shift, nurses must document clearly and completely. Record vital signs and urine output every hour. Summarize intake and output, and note fluid or edema status. Always document any abnormal findings and the nursing actions taken. Then sign and include the time. For example, 9 o'clock, BP 96/58, HR 102, urine output 15 milliliters per hour, physician notified, 500 milliliters normal saline bolus given. Continue monitoring nurse M. Good documentation means good nursing. Always record what you observe, what you do, and how the patient responds. Avoid late or incomplete charting, because missing data can affect patient safety. Remember, accurate notes not only protect your patient, but also protect you legally and professionally. Now, let's move to prevention and patient education. Our goal is not only to treat kidney problems, but also to help patients prevent further damage and manage their daily care. Good education empowers patients to take part in their own recovery. The goal of prevention and patient education is to delay kidney disease progression, prevent complications, and help patients improve self-care. Nurses play a key role in teaching patients and families about kidney health, diet, and daily habits. To protect kidney function, lifestyle control is essential. Keep blood pressure below 130/80 and take medicines as prescribed. Maintain blood sugar below 130 if diabetic. Stay well hydrated, about 1.5 to 2 liters a day, unless restricted by the doctor. Avoid nephrotoxic drugs such as NSAIDs, some antibiotics, and contrast dyes. Quit smoking, because smoking worsens kidney damage. And maintain a healthy weight through balanced diet and regular exercise. For kidney patients, diet control and education are key parts of care. Use low sodium, less than 2 grams a day. Avoid canned or processed food. Limit potassium. Skip bananas, oranges, tomatoes, or potatoes if potassium is high. Lower phosphorus by cutting down cola, nuts, and dairy. Keep moderate protein, about 0.6 to 0.8 grams per kilogram per day, unless on dialysis. And ensure enough calories to prevent muscle loss. Educate patients to recognize warning signs like swelling, decreased urine, or confusion. Encourage regular follow-up and lab checks. Teach fluid and diet management, and remind them to take medicines regularly, especially antihypertensives. You can also provide written or visual materials for home review. Nurses play a key role in patient education and prevention. First, assess the patient's understanding and motivation. Know what they already understand. Provide individualized teaching using simple and clear language. Reinforce key points at every dialysis or ward visit. Repetition builds habit. And always coordinate with dietitians and physicians to maintain continuity of care. Remember, education is prevention. By empowering patients with knowledge, we can slow disease progression and improve quality of life. To summarize, we've learned about AKI, CKD, and IHD, understood their causes, symptoms, and nursing care. We also discussed electrolyte balance, documentation, and patient education. Remember, early detection and consistent nursing care can make a real difference in patient outcomes. Your role as a nurse is not only to treat, but to observe, prevent, and educate. Every action matters. This chapter summarizes all the key points we've learned, including renal function, AKI, CKD, hemodialysis, and electrolyte management. It helps nurses connect theory with clinical IC practice and prepare for both evaluation and real patient care. Remember, knowledge becomes powerful only when applied at the bedside. Here's a quick comparison between AKI, CKD, and IHD. AKI begins suddenly within hours or days and can often be reversed if treated early. It's usually caused by dehydration, shock, or nephrotoxic drugs. You'll notice a sharp drop in urine output and a rapid rise in BUN and creatinine. Nursing focus, early detection, and proper hydration. CKD develops slowly over months or years and is irreversible. It's mainly due to diabetes or hypertension. Urine output decreases gradually, and BUN and creatinine remain high. Nurses should focus on blood pressure, blood sugar control, and regular lab checks. Finally, IHD or hemodialysis is not a disease. It's a treatment for kidney failure. It supports patients with ESRD or severe AKI and nursing care centers on vascular access and preventing complications. To summarize the nursing priorities, we need to monitor vital signs, urine output, and key labs like BUN, creatinine, potassium, and sodium. Record accurate intake and output, and check daily weight. Report any sudden change in urine amount, blood pressure, or lab results immediately. Prevent infection, fluid overload, and exposure to nephrotoxic drugs. And finally, always educate patients on fluid control, proper diet, and medication safety. Early detection, accurate documentation, and continuous patient education. These are the foundations of renal nursing care. Remember, nurses are not just observers. We are protectors of kidney function and patient safety. Thank you.